Well, we'd like to welcome everybody. I'm Michelle from Michelle RX, and this is Dr. Danielle Tate,
Hello.
a maternal-fetal medicine doctor. She's here to answer anybody's questions about MS and pregnancy. Do you have a limit? Is it just MS and pregnancy?
No, I am an open book.
All right.
So whatever we want to talk about today, I'm happy to be here to assist, share,
Yay!
overshare, however we want to call it.
However you want to do it.
Yeah.
Okay. I know. I have a question.
I'm ready.
All right. When you have MS patients that I hope this isn't a setup because we didn't practice anything. We
This is fun.
just sat down.
This is the nature of high risk pregnancy.
Yeah,
you never
know.
You never know, but you're always prepared.
Exactly. I got a question. Okay, what if you have an MS patient? Remember how we talked about earlier that if an MS patient comes in with they can't feel from their waist down, or they have mobility issues anyway, like say they already have trouble walking.
Mm-hmm.
Do you notice those patients, one, having more than one child? Two, do you notice that their mobility over time becomes more labored as a result of having the baby?
I will say the answer to your first question is they don't have many children. Most times, one, maybe I'm seeing them for their second pregnancy.
Mm-hmm.
And really, if they are proactive, meaning they're in the care of their multidisciplinary team and everything stays stable, their mobility usually doesn't adjust. Now, during pregnancy, as we discussed before, because of the imbalance, right? You're carrying that little human in the middle part of your body. And as long as they're able to proactively stay active, which let's just be honest, most people in pregnancy are less active because of the pains of pregnancy, then they have a lot of success.
Okay.
Mm-hmm.
All right. That's good to know.
Yeah.
Because sorry guys, this was a personal question. Because I was wondering about that. Like, if you start off, for lack of a better way to put it, if you start off with a deficit, do you notice that women feel comfortable doing it again, or do they return back to the deficit after? Because you said you return back to where you started when you got pregnant, so you return back to that deficit.
I will say any of my patients who have limited mobility, it really is about support systems. And let's just face it, if anyone makes you feel like you're a problem in any walk of life, you're more likely to shy away. But if you approach it as this is just my unique version of this normal thing that happens to a lot of women, then it's your mentality is set.
Exactly.
And I think a lot of times too, providers may shy away from discussing that. So what's your plan if you're wheelchair bound? How are you going to manage taking care of this baby in the middle of the night?
Exactly.
How we're going to manage recovering from a C-section, if that's the case, and being able to move. Is the family aware, the support system aware? Are there things out there? Because I've connected patients to home health.
Really?
Just with it's an activity of daily living.
Exactly.
Right?
Exactly.
And they may not realize what they qualify for in the recovery of things, even in the most straightforward situation. And so a lot of times connecting them, say, to case management or social work is a great thing. Even going back to their insurance company and having a discussion, because right now in this day and age, especially where we are in Tennessee, there's so many pregnancy-related resources that are just free, sitting out there. But what I find is the resource has a hard time connecting to the patients and the providers to let them know.
Wow.
Just for instance, Blue Cross Blue Shield.
Okay.
In Tennessee.
Okay.
Specifically, the Medicaid version has an app just for pregnancy. You download the app, connects you to a myriad of free resources, mental health, housing assistance, social services. 100% of my patients that come in my office are not aware. And when I talk to the representatives, I said, well, how are you getting this information out? And they said, well, from our website. And I said, well, let's be honest. Who's going to your website just for kicks?
Just for kicks.
Right? You're going to dispute something or pay something, but no one's thinking that's how I'm going to connect to the information. And they're like, well, we mail it. Again, who's going to the mailbox? Or maybe even an email these days. Right. So that's one thing that blows my mind is that people don't either know the resources there or how to tap into it. And if we don't know as providers, we can't even be a resource to them.
Exactly.
Right?
Exactly.
So More to come with that. Like, you got to bring the mountain of Moses. This is where social media is your friend.
Exactly.
Because what I am concerned about is we have this resource, no one uses it, funding goes away, and now everybody needs to use it. But it's not there anymore. So,
Because nobody knew it was there in the first place. Spread the word. Because I did not know it existed. Because that in and of itself is a large mountain to scale. Is who's going to take care of this baby? If the spouse is working and you are at home recovering from a C-section with a new infant, who does that? You never even think that. And what if your parents are older or your parents are in a different location? What do you do? So you would reach out to these people and they would help you. And all of this is state funded? Is it state funded?
It could just be part of the insurance plan.
That you already have.
But people don't realize how much of the not normal pregnancy fits into, because it's such a normal thing, right? But it's like, no, you qualify for physical therapy just for being pregnant, right? You'll qualify for certain medical supplies just being pregnant. But you have to know about it.
Wow. Do y'all know about that? I didn't know about that.
Now you know. The more you know.
Now you know.
Little rainbow just came back.
Huh?
So the little rainbow just came back.
The rainbow.
Yeah, you know, when we were kids, rainbow.
Yes. Reading rainbow. Remember that?
Yes. The more you know.
Did we just date ourselves? Reading rainbow?
Yeah, probably did.
Yeah. Okay. I don't see any questions. Anybody have any questions? Oh, wait. I know what I need to do. I don't know how to do it.
You have to open the chat.
Well, I think I have just the for practice. I did subscribers.
Okay.
Because there's grace in trying to figure it out as you go with the people who've said yes, I will join you, but this isn't the last time.
No, it's not.
It's not the last.
You can always submit questions once you post it.
Yeah.
There could always be questions we can respond to in the comments.
Yeah. I don't see any more questions. Guys, I don't have any more questions. Y'all have some questions? Well, we can just talk right now. You want to talk?
Sure.
Okay. When was the last MS patient you had that you treated, that you delivered?
2024.
Okay. How is she now?
She's amazing. She did great. She made it. No mobility issues to the end of pregnancy. No issues with flares. She stayed in contact with her neurologist, who saw her maybe once in the pregnancy because she was still on the routine. Typically, most of your subspecialists outside of the pregnancy-related ones are going to continue their routine. And a lot of times I have to remind patients of that and their OBs that we do things differently in pregnancy, but I can't always guarantee that your other specialists will agree to doing that. So that's where MFM comes in. And I'll give you an example. Okay. You have thyroid issues.
Got it.
We like to screen every trimester. Okay. Because the thyroid works harder.
Yes.
But your primary or your endocrinologist may only screen once a year. And they won't change that. So that's where we come in. Or if your OBGYN knows, they are going to do the same.
Okay.
So a lot of times, if everything's going well, the doctor will either see you after you've delivered to resume care, or they'll stick with their routine, which is not very frequent.
Okay. Speaking of thyroid issues, something that I've noticed just in working in a women's hospital, a lot of postpartum patients experienced hyperthyroidism. Have you noted, or is this supported data, that women become hypo or hyperthyroid postpartum?
Very true.
Okay.
Especially those with pre-existing thyroid disease. And it goes back to what I just mentioned, that the thyroid works harder. So the pregnancy hormones tell the thyroid to put out more hormone. That hormone crosses over into the womb and helps the baby's brain develop. Exactly. So when you have someone with an underactive thyroid, especially, you have to make sure their thyroid's rising to the occasion.
Got it.
And keeping up. And a lot of times you have medication adjustment.
Mm-hmm.
The opposite typically with overactive thyroid, even though at times you have to adjust medication, but there's triggers of pregnancy, say morning sickness, really bad, can put you into that thyroid storm. So what happens is once the pregnancy's over, now the extra hormones are gone and this thyroid's trying to settle back to normal and it can be thrown off, whether you have over or underactive.
Exactly.
And so it will throw things off. And it's really interesting because a lot of times the symptoms overlap with routine pregnancy or postpartum.
Exactly.
One of the most common ways for what we call postpartum thyroiditis, which is the thyroid not working well, believe it or not, mental health. Yes. It'll present as depression. Yes. Not as I'm too hot or too cold, not as my hair standing out, which is another thing that happens postpartum.
Exactly.
Not as my sleep disturbed or I'm sweating all the time. It's depression.
It's depression.
So when I talk to my mental health colleagues, that's one of the first things they'll report back to OB or primary care to screen their thyroid when they have new onset postpartum depression.
Makes sense. Wow. Mm-hmm. Well, let me ask you this. You mentioned the nausea, the vomiting. Is hyperemesis gravidum connected to hyper or hypothyroid? Or put it like this, is hyperemesis gravidum connected at all to the thyroid gland?
It is, but not like you think.
Okay. Because you know what I'm thinking.
Yes.
You know what I'm thinking.
Okay. So it can, in a way that it could be a trigger for the thyroid to not work well.
Okay.
So there's a pregnancy hormone, and if you're nerding out, this is your cash cab moment, beta HCG. Mm-hmm. That's one of the big pregnancy hormones. It also looks like thyroid stimulating hormone. So the hormone that goes to the thyroid, knocks on the door and tells it to release, looks very much like that pregnancy hormone. Exactly. So much so it's called alpha HCG. Okay. And so what happens is at the beginning of pregnancy, that beta HCG goes up. She's vomiting, she's sick all the time, and it goes up more, and then it throws the thyroid off. So it'll make someone look like they have hyperthyroidism or overactive thyroid. They don't.
They actually don't.
Yeah. So routinely, we say don't just screen people's thyroid just because.
Right.
Because you'll see off things which are normal changes that then settle by the second part of pregnancy when the morning sickness is over.
Gotcha.
And so with that, though, it could, if someone has pre-existing issues, could push them over into an emergency type situation.
Gotcha. Like Graves' disease emergency situation?
Right, like thyroid storm.
Okay.
Mm-hmm. It can look really bad.
Okay.
But most times it's just a false change. And if you wait it out, get the patient better from the nausea vomiting standpoint, the thyroid settles back down and it'll work well.
Okay. It's interesting because it's almost, we're having our own little private conversation. Yeah. Nobody's asking questions yet. So
I like to talk.
Let's just talk. But literally, this is interesting because of the similarity in the hormone, it sounds almost like a chicken and the egg. Does pregnancy beget nausea vomiting, or does nausea and vomiting beget thyroid? Basically, your thyroid hormone going crazy. What comes first?
I would have to say the pregnancy will trigger these things. And who knows why? We know why some people are more prone to having nausea and vomiting in pregnancy. It's known well with female fetuses. It's known with multiple gestations. So everybody wants to have twins. Mm-hmm. So one of the things you have to look out for, if you have a known history of something, right, that already issues like really bad heartburn, things like that. People have slowing naturally from other conditions of their stomach and GI system. That will trigger it more.
Okay.
And so you have that, and then it's this cycle, right? Because most people are going to try to fight it out without taking medication. They may not realize they're pregnant.
And there's that.
And it's just a vicious cycle of going kind of further and further into that hole of sickness.
Gotcha.
Until they show up in the hospital.
Gotcha. Speaking of hyperemesis gravidum, we typically use the vitamin B6 and the doxylamine to treat it. Mm-hmm. Is there any connection with that and the appearance of the organic structure of thyroid hormones that causes it to wane?
It could be, but usually it's treating the end effect and not the source, if that makes sense.
Makes perfect sense.
And hyperemesis gravidum is just the extreme nausea vomiting version where I'm losing weight, I can't keep anything down, all my electrolytes are off, I'm at the hospital super sick. Morning sickness is the milder version, right? I get nauseous, sometime throughout the day, but I can still eat and drink, maybe not as much. And I can kind of subside it with things from the pharmacy or mild supplements or prescriptions. And it's really interesting how much people can tolerate. And so I just morning sickness. You haven't eaten for 2 weeks. That's not normal. That's not in any way. Hyperemesis is an interesting one because it is very extreme, but it fixes itself so fast.
It does.
Yeah. So just a few things. Very interesting. Morning sickness usually happens for most people in the evening. Don't know why somebody called it morning sickness, but people do. Some people will have it like all day throughout the day, but it peaks a lot more in the evening. Don't know why. It's not as if your hormones peak in the evening.
Right.
But that is always one to know. So I find sometimes people may confuse it, thinking morning sickness is going to happen in the morning. So this is something else. 2, we have to give credit to lifestyle before and things going on before. For instance, if you're a diabetic patient, a lot of times you know how diabetes will affect the GI system. Now enter pregnancy, where pregnancy's job, part of the hormones, is to slow your GI system down to allow nutrition to get into the body for you and baby. And if you already got a problem with your stomach emptying and your GI system being slow, now we enter the slowness that gets you really sick.
Exactly. Okay, that makes sense.
And then my favorite one that no one talks about that we should ignore is what's called cannabinoid gastroparesis.
Yes.
It's our favorite way of saying you smoked a lot of marijuana, maybe some edibles, some version of THC, and now it's made your GI system slow. And really not even slow. It's actually a version of withdrawal. So what you have is someone who's a regular user of THC who then gets pregnant. I'm going to stop everything for the safety. And now they go into withdrawal and it looks like really bad morning sickness.
Yeah, because you cause peristalsis. And that's what it is.
And a lot of times that gets confused. And if you're not someone who does OB care a lot, say like an ER doctor, they're not going to realize that that's what's going on and how to treat it appropriately. And they'll just keep coming back to the ER, right? Until somebody finally sits down and gets a good history. And what ends up happening is they get sick, you get them a little bit better, then they reintroduce themselves into the environment. They don't have to be using themselves, but if they're around secondhand smoke, it's just
the same.
Or they may go back to it to help their appetite, or not even connecting the dots that it was because I stopped. And that's why I'm sick again. But it literally will last a few days and they're back to normal. But they will be some of your sickest people in your triage or emergency room until you get them better. And the telltale sign, and I always tell my residents this, the telltale sign is hot showers. For some reason, only with the withdrawal do you get this relief from the steam. So they'll sit in the hot shower and they get for hours to get relief from the nausea and vomiting. So that doesn't work for hyperemesis, doesn't work for morning sickness.
Just with THC withdrawal.
And again, once they get past withdrawal in a few days, they're fine unless they reintroduce THC into their system. Internally or externally. Got it. Yeah. Really, all the stuff we know about it is primarily around smoking it. There's not as much on edibles or ingesting it that way. But with time, as things get more and more legalized, I think we'll have a really good grasp on its effect on pregnancy, period. Wow. So
I'm learning way more than I thought I was going to learn. Wow. I'm not even pregnant. And I'm like, this is so interesting.
It is.
Wow. Okay.
Yeah. But when you talk about good old-fashioned morning sickness, you're right. You brought up vitamin B6 and Unisum. Those are actually the recommended first go-to.
Yes.
And so I usually tell my residents, I say, okay, she came in, she was sick. What'd you give her? Well, we gave her some Zofran. So, okay, well, that's a common one we use for nausea and vomiting inside, outside of pregnancy.
Zofran, to everybody else, is ondansetron.
No.
It's ondansetron. Because a lot of people know it as ondansetron, which is odd to me. But yeah, Zofran and ondansetron are one and the same. Keep going, doc.
But they'll give it because you can give it IV, right? We let the stomach rest. We give them some crackers or something. And then we send them out with another prescription that we didn't test, that we don't know his work, and we didn't tell them how to use it. Like, okay, this isn't helpful. Why not test what you want them to take at home? But anyway, I digress. Vitamin B6, Unisum are great because you can get them over the counter.
Mhm.
They're for a few dollars. Vitamin B6 is all natural, which is always a conversation these days about man-made treatments versus more natural ways to do things. And it's a great start. Ginger is my other go-to. That's one of the first line ones. Everything but ginger aid. Or Ale, sorry, ginger ale.
Ginger ale.
Ginger ale. Ginger ale has no ginger in it. It's some magic in it that worked when we were kids. But you might as well just like drink a Sprite or 7-Up. But I think it's just the color of it. Maybe somebody named it that.
Okay.
But there's ginger beer, which is non-alcoholic. I have a lot of patients that will sip on that throughout the day. There's the ginger chews, the ginger pops. There's the slices. I have one patient tell me about aromatherapy patches. You can only get them online. We can't prescribe them, but you wear them kind of like you would do Vicks Vapor Rub. And it's like citrus or lavender scents, and it helps a lot. So there's a lot of ways you can help with it without having to feel like you have to take prescription medication.
Exactly.
I understand the hesitancy with that.
I totally do, especially being pregnant, because that's a very normal concern women have is, can I take this while I'm pregnant? And ginger is fabulous for nausea and vomiting. It's all natural. Like, yeah. Do you notice that women like basically can shave off a little ginger from an actual ginger root and chew on it, or if they can handle that?
They can, and that's the big thing. It's a really strong.
It's very strong.
It's strong. Even when you're cooking with it, right, and you put it in as an ingredient, it's a strong, powerful thing, and it can give a burning sensation. So I like that there's the options where they kind of dull that part of the effect of it, so you can tolerate it. So,
well, since we're talking about natural, I'm just going to keep talking, guys. We're just going to have a great time.
I'm going to give you guys all kinds of things to follow up with.
Right?
This one, so
follow up
come
on.
back.
Yes, we're going to come back.
It's a little gumbo today.
Yes,
a little gumbo.
And we're actually both from Louisiana.
So we know our gumbo.
We know gumbo. We know gumbo.
That's right.
We know it. Right. And we know when it's not gumbo.
Listen, I'm very uppity about my Cajun food.
Yeah, I'm a gumbo bully.
And I don't know how I ended up living in cities where no one knew what to do.
Yeah, and it's like, what is it?
But you learn, you find other people.
You find other people.
Figure out how to cook it with the ingredients we have.
It's like, okay, we'll make it. That's okay. We'll just make it. I'm sorry, guys. Back to the point. Back to MS and pregnancy, or pregnancy in general.
Just pregnancy in general.
Let's talk about pregnancy. As far as natural supplements, like not just morning sickness or hyperemesis gravidum supplements, women sometimes, because of the center of gravity, they struggle with balance. Do you, one, notice that they struggle with balance, and two, do you have alternative ways of managing that balance or non-alternative? And what I mean by non-alternative are prescription drugs or legend drugs in your practice.
So this is a great topic because I get asked this more and more about natural supplements in pregnancy, period. Because a lot of people are taking natural supplements more and more at younger ages, which makes sense. There's a very short list of natural supplements that are not safe in pregnancy. And the one that really bolds and tops the list is vitamin A. But most people aren't taking that unless you're treating, say, acne. But outside of that, vitamin C, which a lot of people do when they're sick or getting sick, right? Emergency things, safe to take. Vitamin D, highly encourage that. We're all deficient. Most of us are because we sit inside all day. Remember, with vitamin D, you have to activate it. So you need to be outside in the sunshine for at least 30 minutes a day for it to actually work.
Exactly.
Turmeric, safe. Cotin, safe. My favorite one in the world right now is magnesium.
Safe.
Don't get the drink. I think I mentioned this before last time. Don't get the drink. That's gonna clear you out. I mean, if you need to get cleaned out.
If you're getting ready for a colonoscopy, it's your friend. Mag citrate is your friend. But if it's mag ox, you're safer. But if it's mag citrate, that's the drink. You don't want that. It will embarrass you.
No, you want the tablet form.
Right.
And there's, like you said, oxide, there's glycinate, biglycinate. I even have some patients that say even milk of magnesia helps with the magnesium in that helps. So I said, okay. But needless to say, it's a great kind of overall where you mentioned aches and pains of pregnancy, constipation, headaches. It covers all those things.
I just had a pharmacy moment.
I'm ready.
Be careful with the magnesium, that the milk of mag. If you actually are pregnant and you have a UTI and you are on an antibiotic, the magnesium will bind the antibiotic. So it's like you never took it. That's a drug interaction. You can take it. It's safe for baby. It's safe for you, but your UTI will not go away. That was just a pharmacy moment.
Well, I'm glad you brought that up because it is really important to let your OBGYN, midwife, nurse practitioner, family, OB doctor know what supplements you're taking. A lot of people don't think they have to report that because it wasn't prescribed. But for moments like that, we would need to know, make sure it's in your file, and we recognize any potential drug interactions because we want things to work or not have a negative effect, right? And that's very important to know. I have so many patients who think we're just in the kind of the business of babies in the womb, but everything crosses that. Your heart crosses that, your lungs, your kidneys, your history, your allergies, everything. Oh, I didn't think you need to know that because you're just the OB doc. And I was like, no, everything matters.
Everything matters. And we've talked about this before in prior videos. It's all connected. It's all connected. And FYI, we're not just colleagues, we're actually friends. And we literally bounce stuff off each other. Like, what do you think about this? Or what do you think about that?
More me.
No, it's the other way around. It's like,
help me with this.
What is this? No, we both do that. Like, what do we do? But that's what continuity of care is, because nobody is an expert in everything. Do not ask me to deliver your baby. You will sue me. For certain. You would sue me. So
just don't take the bed away. Everything works its way out if you just leave it in bed. Baby is very resourceful. They'll find their way
babies
out.
know what to do.
Yeah.
Okay.
I had that happen once, so that's
really?
why I laughed. Yeah, the epidural was really good. And she called out and said, something's moving under the sheets. And it was her baby.
Okay.
So I was surprised the baby didn't cry. So I think the baby was confused as to, what is this? Because the sheets covered, the lights were out because everyone was sleeping in the room. So that's pretty funny. Yeah.
I don't even know how to respond to that.
Listen,
Listen.
Routine day in OBGYN.
Baby delivered itself. That's okay. And everything was normal.
Oh, baby was perfect.
Baby.
There's no issues at all.
Okay.
I just surprised the baby didn't make any noise. Yeah.
None?
No noise.
No music.
They saw the sheets moving.
That was it.
They said something's moving. And they knew it wasn't her because she had an epidural, so she couldn't move her legs. So.
That's weird.
I'm sorry, we veered.
Sorry, y'all. We digress.
But yes, most supplements. I hear calcium. I hear turmeric. That's safe in pregnancy. Anything else? I'm trying to think of the ones I usually hear. I hear a lot of turmeric, magnesium, and then of course a prenatal vitamin is safe in all ways. What makes a prenatal vitamin, as we've discussed before, is the extra iron and folic acid. If you're getting other things like DHA, that's perfectly fine. They don't have to be there. They're a bonus. So if you're not able to get that covered by your insurance, or you can't find it at your local pharmacy, my warning though with any of these supplements and prenatal vitamins, make sure you're getting them from a reputable source. So I've had a few patients in the past that bought from like online natural pharmacies, and they weren't FDA regulated. So they were actually getting medications from different countries and they didn't realize it, and they had things in it that were unsafe for the pregnancy.
Right.
Same with even going to a store like GNC. Do they still exist?
Yes.
But a lot of the things they carry, right, especially when they're more holistic medicine versions of things, they're not regulated. So you just have to be careful. Always ask your OBGYN to look at the package for you. Send them a picture.
Or your pharmacist.
Or your pharmacist, right?
Because that's true. That's very true. Because just because it's cheaper, or just because it is procured from a different country, you are really taking your life in your own hands. And I say that not lightly, because even if it is FDA regulated, the FDA, like supplements, they can't regulate how much of a supplement is in a particular capsule or tablet. So that's even done with a seatbelt. You don't really know that either. So be careful before you just decide to take things that are not made stateside. I mean, I hate to say it like that, but you, for your own protection, I would. I mean, for example, I'm a pharmacist. I can't co-sign on something that was not prepared that I can track. I can't co-sign on that. So I can't promise you that you and your baby will be safe. That's what I mean by that.
I agree.
So be
reputable
careful.
Sources, right? Even a generic version of a reputable source is fine. So if you're buying the Walgreens version or the Walmart version, it's perfectly fine because that's the reputable pharmacy.
Exactly.
Or manufacturer.
Yes.
It's when you go to the ABC 123 pharmacy that no one's heard of. And it's like, be careful. Yeah. Even Amazon, that's a reputable resource for a lot of supplements. They just sell the same things in-store, in-person pharmacies.
Exactly. But like you said, if it's ABC 123,
you just have to be careful.
I wouldn't do that. Okay. We still don't have any questions, but I'm still going to ask. Do you have anything you want to talk about?
I can always talk.
Go. If anything you want people to know.
Well, I mean, there's so much.
Where do you What's your biggest beef right now in the world of OB?
Well, I will say, I feel, we're going to go on a really big tangent.
Okay, go.
I feel like one of my biggest things now is the inaccurate reputation that traditional OB medicine is getting.
Go.
I.e. meaning, don't deliver at a hospital, you'll die. You don't need an OBGYN. They don't care. I'm like, wait, who's putting this out against us? And, you can track through more popular ways people get information to see these things. And we touched on this the last podcast about just how to make sure you are standing up for yourself. You are having a voice. If you don't gel with your provider, finding another one, being able to advocate, right? And I think a lot of that loss of ability to advocate is how a lot of these things have been birthed. To say, well, I'm just going to say that one doctor I had who wouldn't listen to me, and when I said I didn't want a C-section, now all of the same type of doctor is the same way, right? And it's like, well, no. But let me show you how to navigate the system so that you can make sure your best interest is always at hand.
Got it.
And I tell people all the time, as you probably heard in other things, where they say closed mouths don't get fed. So if you close mouths don't get answers either. Exactly. And so if you're quiet, we're going to go to our default of how we do things because we know that's a safe way to do. Is it the only way? Rarely is it.
Right.
But at least it's a way. Right?
It's a way.
And then being able to kind of respectfully introducing your concerns and questions during your doctor's visits or your provider visits, I should say, when we're limited to OBGYNs, or when you get to the hospital, tapping into things. There's so many patients I tell these days, go take a tour of the hospital. They offer them. They're free.
Yes.
They'll have someone one-on-one walk you around and answer all your questions. Get a feel of the room. Know where to park. Know about the visitor policy. Yes. Where does the baby go after being born? Who's in the room?
Right.
Right. All those things. How do I make sure no one knows that I'm here?
Right.
Or can I make a list?
Right.
A lot of times people don't realize, we at the hospital will be the bad guys. If you don't want anyone to disturb you, they're not going to disturb you.
They're not going to disturb you.
Or do you have these aids so I can have as natural of a delivery in this traditional setting? And then you understand, well, we have this and this, but you can bring this in. You can bring your doula in. This is how we work with doulas, right? Or we don't do this, or understanding if you want this, but you get this. For example, you want a natural delivery, but you get an epidural. You can't really move the lower half of your body well. So being able to walk around is a thing that goes away. And so, for instance, we have a local hospital here that now does nitrous oxide. But the word isn't out in the community, which I think is an amazing resource when you have people say, I want to go all natural, but they know they don't like paying that much. and they know they don't want to do narcotics, or they know we can't give narcotics until the end, right? And you say, well, there's this laughing gas option. Like, oh, I like that. I said, but check on your insurance. Can you deliver at that hospital?
Exactly.
Does your doctor come to that hospital to deliver people?
Right. Does your doctor know how?
Mm-hmm.
No disrespect to other OBs, but that's not conventional.
Mm-hmm. No,
Nitrous oxide is not conventional.
But I love the idea of having options,
Yes.
right? And you really don't know until you know. And a lot of times people don't find these things out until it feels like the point of no return, like you're locked in, and I can't go back in whatever decision or plan that's locked in for me. Right.
Wow.
Yeah.
I never thought about that, that nitrous oxide would be an option, although it makes perfect sense that it would be an option.
You think about somebody's drilling into your teeth and it really doesn't hurt.
And it's
when you're breathing it in.
Literally, you're like, haha, this is great. No, it's not. It's not great. But you think it is.
You can laugh through it.
Right.
Instead of cry.
I'm going to laugh instead of cry. Oh my gosh.
Yeah.
Oh my goodness. Okay.
And I used to be a not fan of birth plans just because I'd seen so many times that the more strict it was, the more points and numbers, it always failed. Like we always ended up at the opposite end of their birth plan. So, but what I've learned recently is to have a birth vision. So a birth vision is very much so fluid.
Gotcha.
And it's fluid from both aspects, meaning I'm coming in understanding that this could change in any way. And the people helping me deliver my baby understand that this is a template, but it doesn't have to necessarily follow. I am flexible in the ways that are safe for me and my baby. I'm not going to say because there's no all nothing, but that's how you practice. You're very dynamic in the way you practice, but that's what makes you good at what you do because you can ebb and flow safely with the desires of the parents, specifically the mom, since she's the one birthing the baby. Is that a common mindset among OBs, is being dynamic and flexible, or is that you? It is, but I think it's layered in why you would give variety. One, a lot of it is on experience. And so like anything else in the world with any of us, if we had a bad outcome or something nearly happened bad, we tend to shy away or change the way we do things to avoid getting in that situation or putting someone else in that situation.
Okay.
So you'll get a lot of experience-based practice, which is not a wrong thing, but it's more of, well, I know from your experience you don't do this, but you're not answering my question about whether this is safe or not. Right. And so kind of navigating, I find patients have a hard time starting that part of the conversation without feeling like they're being disrespectful. Right. But you can definitely do that and saying, well, can you share with me why you think X would not be a good idea?
Okay.
Instead of saying, well, I saw on TikTok or I Googled it, and it's like, okay, they're going to shut you down because they are like, I'm the doctor or I'm the provider. Right. And so I feel like that is one. And then two, I think people just get into the, we get in autopilot really, really quickly when we're doing something on a daily basis, including our jobs. And you don't think to stop and think about the patient's perspective. So if this is my literally 1,000th pregnant woman I'm taking care of, but it's her first baby.
Right.
That's different.
Right.
She doesn't know what to expect.
Right.
She doesn't know what to put in her hospital bag.
Exactly.
She's super scared because she doesn't know if it's going to hurt. Is it going to work? Is her body going to let the baby out?
Right.
All those things. So if there were providers listening, I say, hey, be proactive. And I teach my residents sometimes, have something to talk about every visit, right? Because you're going to have at least 10 visits with this patient, with your provider. Everything should be a milestone of talking. Okay, we're halfway through. Let's talk about this glucola test that you have to drink and why that's important. And I'm sorry, I had this allergy to high fructose corn syrup. Okay, we gotta make a plan.
Right, because we can't do that.
Right, you did your other 2 pregnancies and you threw up.
Right.
So that was a problem. What's our alternatives, right? Okay, now we're at month 8. We're entering in the 3rd trimester. Let's talk about getting ready for the hospital. We'll talk a little bit about every time. Do you have your backpack? You got your phone charger?
Right. Do you know what goes in your bag?
Right. You have to have a car seat and the right one.
Yes.
Because I just learned recently that some of those discount sites are selling knockoff of real car seats and they're not car seat approved. So
exactly.
The parents are getting there with the car seat and getting turned away because it's not They have to go buy a new one because it's not a safe one, even though it looks pretty like the one that's 3 times as more or more.
Literally. Because you bring about a great point, because we work at the same hospital and my office is behind the nursery. And a lot of times, not a lot, but it's happened where families can't afford the appropriate car seat. Are there programs for that?
There are. In my experience, they may not be as consistent. So a great place to always start is the health department.
Okay.
Because when you think about this need, it's kind of a fundamental one. If you can't get this baby around safely, it's everybody's problem, not just yours.
And it's all of our baby.
And so those fundamental things they'll have deeply discounted. At one point, the health departments locally in our county, they were $5. You just had to get to the health department to get one. You know, same with things like pack and plays. So if you unfortunately have unstable housing or maybe not a lot of furniture, that's a great one to make sure baby's safe at home. Again, it's about finding the resources.
Yes.
You know.
Wow. Thank you so much, because I think that's a huge gap between knowing that there are resources and people actually knowing where to get the resource or where to find the resource. So thank you for mentioning that, because I honestly did not know. And it's very sad to see the baby is kind of stuck until they can get a car seat. And you're like, I'll go buy you one. But you're like, I'm at work. I can't go buy you one. But you feel so bad. You know?
You really do. You realize, too, how much the people closest to them may be out of touch. So when you're looking at grandma in the room, grandma's youngest kid is 27. She is totally disconnected about anything and everything. It's all new. You know, like I look at my mom, I'm about to really date myself. She put me in cloth diapers, and it was Pampers when we went out. So now she has to look at grandkids and say, I don't even know how to work this.
What is this? Right.
I don't understand any of this.
Right.
So you just have to realize they may not have the educated resources around them. Enter in the doulas, right? That's really a big part of why they exist, is to help with education. And as a patient, and I think you can carry this anywhere in your healthcare journey, you can always be proactive for the next time. So, okay, when I come back, can we talk about breastfeeding? Because I'm really interested in that.
Okay.
Because a lot of times docs are saying, providers are saying, I want to talk about that, but I gotta go to the next patient. And I already had my plan for you. We covered everything. I got to move on. Time constraint. You're feeling like, no, I want to talk. It's like, okay, we can table that and we'll talk about it your next visit. I'll make a note. And I'll make sure we bring in resources, or I let my nurse know so she can do the talking. Whatever it is, we'll get you connected.
And it's good to have a list of questions, like, because you're going to be thinking of questions as you go. Patient, you're going to be thinking of questions as you go. If you, like, everybody has a cell phone. So keep your questions in your cell phone and just go down the list to be efficient, right?
It is. And pregnancy brain is a real thing.
It's real.
A lot of times patients, in the middle of our conversation, she's like, I had a question. I can't remember the question, but give me a minute. There is a question. I said, pull out their phone. They're like, oh yeah. And, you know, so and all of us can get in that moment of, you know, forgetting what we wanted to ask or cover. It doesn't, like you said, hurt to keep it somewhere that comes with you all the time to the office.
And in your husband's phone or your partner, however you do it. Keep it somewhere, because you're not going to remember everything.
No, really not at any point.
And that's a non-pregnant brain.
It really is, because you don't know. And a lot of people, when they come into the visit, are already kind of anxious about what to expect. What news am I going to hear? Especially if you're high risk pregnancy, they're already holding their breath every visit, waiting kind of for the shoe to drop moment. And sometimes everything erases once you cross the office threshold.
Literally.
I just need to I'm in survival mode.
Literally.
Make it through my visit.
Literally. Let me ask you this. Let's see. Yeah. We're almost done.
This is fast.
It is fast.
It's like chit-chatting.
It is. It's because
these are MFMs like to talk. You realize that. Like, we don't even have real exam rooms in our office. We just have tables and chairs so we can talk. So I'm happy to come anytime. We love to talk.
We love to talk. Like, for real. In real life, we love to talk to each other. We love to talk.
Exactly.
I do have a question, though, about we just did a big research project together about diabetes and pregnancy, and the glucola. Let's talk about that.
Let's talk about it. Diabetes is one of my jams. I'll tell you, it scares a lot of people.
Yes, it does.
Because it takes a little bit more brain power as a provider to monitor it, to make sure it's staying safe. It loves to not play by the rules. It loves to look different in every person that has it. And so this is a big part of bread and butter of most MFM's world, is diabetes, whether it's inside or outside of pregnancy.
Well, I'm going to do broad swaths right now. Guideline recommendations for checking to see if a pregnant patient has diabetes, what's called gestational diabetes mellitus. That's done at what week?
So standard screening is between 24 and 28 weeks, which is 6 to 7 months.
Pregnant.
However, there are groups of people or certain people who will meet criteria for early screening, meaning the concern is that it could show up earlier than expected. And so if you have a history of prediabetes, PCOS, or polycystic ovarian syndrome, if you've had gestational diabetes before, if you had it and say maybe lost weight and it went away, you may get screened again for it just to make sure it's not back. Certain BMIs or sizes, if you've had a really big baby and no one knows why. So yeah, my last baby was 11 pounds. That's probably not normal. Those are things that will flag and we'll say, okay, let's screen early.
Do you have to worry about first degree relatives?
You do. Definitely first degree relatives, so parents. And that's type 2 more than type 1. Because type 1's usually, it's in the family. It's more of a genetic linkage to that. So yeah, absolutely. So if you have typically a BMI over 35, it's very low, and you have a father with diabetes, you're probably going to get screened. So,
right. Okay. So one of the things that a lot of women who are pregnant that do get diagnosed with gestational diabetes, just broad swaths, this is just a conversation. If you end up with hyperglycemia, in other words, your blood sugar is too high when you are pregnant with your baby, what are the risk factors to your baby if you have a blood sugar that's too high your entire pregnancy? That's my first question. My second question is this a suggested practice that women are screened for gestational diabetes, or is it a required practice? Do all always do it?
So I answer the second one first, in that it's a standard of care. So what we do know is if we were to go in any population, any average American population, and just started grabbing people at random, there's a good number of them that will have or test positive for diabetes at pregnancy. Now, there is a small group where you can forego it and say, okay, you're fine. But you don't usually find that in your average community of meaning lacking all the things we just mentioned. And really also, they say not being of an ethnicity that's more prone to have higher rates of diabetes outside of pregnancy. So in a community like Memphis, it's hard to find a candidate who you won't screen. Now, screening is interesting. I have a lot of people who don't want to do it. Mainly because either they've been sick before or they don't like the thought of ingesting that much sugar at one time. But the sugar drink is what's been proven to be the best and most effective gold standard way of screening. If you say, well, what's an alternative? You can check your blood sugar for a full week. That means you have to stick yourself. Sorry, there's not a way to get around that. But that's a way to tell. And that will be 4 times a day for 7 days straight. And that will be a way to tell. Now, there are studies out there, and I've done it before with, gummies, jelly beans and licorice, but it has to be a certain brand and of a certain weight, and you have to eat it in a certain amount of time. So they usually give you like 5 or 10 minutes to scarf, say 18 jelly beans, and then wait an hour and check your sugars. Okay. But again, that's high fructose corn syrup. So if you're worried about the sugar content, we're just substituting the type of sugar. Right. Now, that came about because the tolerance of being able to hold that much liquid down is an issue. Okay. Now, that 1 hour, 3 hour, the 2-step testing, if anyone's ever experienced that, That's what's been tried and true.
Okay.
You may hear about a 2-hour test that hasn't been proven to be effective in pregnancy. You may hear about a hemoglobin A1C, that's something else outside of pregnancy, or a random check.
Mhm.
Those things haven't been proven to be effective for true diabetes of pregnancy. Now, some people will, and I'm one who will use those as a means of early diagnosis because
Mhm.
nothing's been proven to be the best when you're diagnosing before 6 months. But overall, we're creatures of habit, so we know the 1-hour, 3-hour method.
Mhm.
So most docs, if not all providers, are
Mhm.
going to use that 2-step process.
Okay.
Now, there's some things online where it's like, oh, you can do an alternative, more natural sugar version. Be careful with those companies. I would definitely take that to your OB provider and let them vet it out and make sure it's whatever product before you order it is a legitimate equivalent to what we
Okay.
would use. And there are a few companies online that do sell like more all natural versions that will still give you the amount of grams of sugar to test
Right.
appropriately.
Right. Okay. Perfect.
Now, I will tell you the OB practice and your insurance won't cover it. So you'll probably have to come out of pocket to do
Yes.
that alternative.
Yes. Yes.
As well, other things that come up usually when you do the 1-hour test, you don't have to be fasting, so you can eat, but please don't eat the biggest breakfast of your life on the way into the office with your sweet tea, because you're going to feel it and it's going to contribute. So I usually tell people eat something light, maybe a few hours before you're testing,
Mhm.
and then come in. Or you can come in fasting, that's fine. It's just a lot of times that much sugar on an empty stomach, that fast, because you have 5 minutes to drink a full bottle, it doesn't sit well with people. And that's how they end up sick.
Okay.
You mentioned about sugar. So basically, we talk about these hormones of pregnancy. I tell you, they are all about pro baby. All the pregnancy hormones are about that baby.
It's all about
you're
that
just
baby.
you're just a vessel for this baby.
Literally.
And what ends up happening, there's a hormone coming out of the womb and it goes over and it says, you don't get to use your sugar like you're supposed to, so it can freely flow into the womb. That shifting is what we're testing for. And that shifting is what's called gestational diabetes. And we know for a fact, literally once the pregnancy's over, it all goes back to normal fairly quickly. So much so that you don't have to do any other extra we give you, even starting in the hospital after having the baby, right?
Yes.
And so you say, well, what's the importance of this if it's temporary, especially? It's not as if I'm a type 1, type 2 diabetic with long-standing issues. Well, here's what happens. When sugar joins the party in excess, so we have more sugar in our bloodstream than we need, from our standpoint, as the person carrying a baby, it can definitely put us in a starvation state. So the extra sugar is floating around, but with nothing to do. Because remember, it's like a key in a lock, say a locked door, open door. Insulin comes, unlocks the door, lets sugar in, and now, yay, we have energy. And our brain works right, and our kidneys work right,
Yes.
and everything, right?
Yes.
That's why sugary things are our happy foods. It makes us feel better when we eat, carb or sugary things, right?
Exactly.
Well, now we have this pregnancy hormone coming and holding the door closed while insulin's trying to unlock it, like, nope, sorry, go away.
Go away.
Right? So now, if I have extra sugar around, my body's not using it. My body's going to say, oh no, we can't die. We're not going to die. I'm going to go into extreme or starvation. Oh no. And then you end up in this sick state.
Yes.
So you're starving, but you got all the food around, you can't use it.
Exactly.
And that's called DKA, if anybody knows. And it's interesting, all the rules are off in pregnancy. So
Yes.
what would be categorized and kind of divvied out amongst types of diabetics outside of pregnancy, fair game for any diabetic in pregnancy, right? Then you look on baby side, the issue comes again with extra sugar. Too much of a good thing in life, like most things. So that extra sugar is like, oh, we have nothing to do. We fed baby, we giving mom energy. Oh, let's go jump over here and make sure oxygen can't get into the womb. So it can literally block oxygen movement from mom to baby. It's almost like taking up seats in the wrong car.
Exactly.
Right. And then also, any extra will freely flow over. It could potentially make the baby too big for the birth canal.
Exactly.
And so when I tell patients this, especially when they struggle with diet changes, right? Because we like what we like. We crave a lot of things when we're pregnant. That you're just like, I got to have it done. It's not hurting anybody. Some of my most, some of my patients who struggle the most are those who have family members with diabetes who may not have the best lifestyle habits. So they've watched this person kind of be healthy and live with it, so they don't understand the impact.
Exactly.
And I tell them it's very much more different than you think. Meaning, I've had diabetic patients who we've, really stressed, really like you're negotiating, you're trying to compromise, please eat the right thing, please do.
Mhm.
And then they just walk in and their baby's passed away. Because over time, if I'm cutting off your oxygen supply little by little, eventually you're going to succumb. And those are your babies that'll make it to pretty much their due date almost, and we'll lose them. And so even if you're in a situation where you're maybe have had this happen and you didn't really understand why, or it's happening to you now, and the docs are really pushing, the providers are really pushing, we need to get you delivered. I don't want to deliver. I don't want to be induced. I don't, like, we just want you to have a live baby.
Yeah, we want you to have a live baby.
If it has to be a little bit earlier than planned, at least we have a live baby and a healthy mother.
Exactly.
Right.
Exactly.
And it's interesting how much of an impact that is, and then it gets cut off right away. It's also interesting the effect of it, because I always tell patients, listen, when you're diabetic, in the beginning it's like feeding an elementary school kid, by the end it's like feeding a teenager. Because that pull, right? A bigger baby's gonna want more sugar.
Exactly.
And that just keeps that effect goes up and up as the baby's weight picks up.
Mm-hmm.
And so what works today may not work next month because of the effect.
Exactly.
So I always tell my patients, please give yourself grace, because this is not an easy journey. We're ruining your life by telling you got to eat differently, and maybe off script from everyone else in the family, maybe for things that you can't afford all the time or you don't really want, right? 2, we're also scaring you and telling you if you don't follow it, and that's what most people do, because you're at home, you're checking your sugar, every sugar needs to be right for you, or else, I'm a horrible person. Not true. We're never looking for perfection, right? And a lot of it's trial and error. So I tell patients, please give yourself grace. Listen, in my experience, just putting the effort forward the entire pregnancy, all I can ask. That pays off so much.
Exactly.
When we work, and that's another area where I find patients are scared to tell. It's like, well, Dr. Tay, you want me to check at 7 a.m. and 9 and 10, but I work nights. Thank you for letting me know you work nights. So what time is your morning? What time is your lunchtime?
Right.
That's what I want you to check, right?
Right.
Oh, I didn't know. No, don't stay up all day trying to check. You don't even eat at that time, It's kind of those things you have to work with them.
Right.
And help them understand. And then to not be afraid of sugar.
Right.
Eat as crazy as what I just said. You still got to eat the sugar.
Because your body needs
the sugar. It's just about moderation.
Exactly.
I tell people all the time, it's like the VIP section of the club.
Exactly.
Everybody can't be in there.
But
we need some people in there partying.
We need somebody.
Special people.
Yes.
So as long as you do things in moderation is the big thing, and it really is true. But the thing is, a lot of times our American diet is not built for moderation of sugar, right? We love to mix our complex sugars. And you'd be surprised how many people have to explain what sugar's in.
Yeah, what a complex sugar is.
Mm-hmm. Like, it's not just the sweet stuff.
No.
That is obvious.
A loaf of bread.
Drinks. Right. Your bread. Listen, the culprits, the big guns are not sweet.
No.
Right.
If you go to Outback and you get the bread that they give you, like as a thank you for sitting here. Wait a minute. We'll bring you a menu. That bread.
It's trouble.
That's a problem.
It tastes good. But yeah, bread, potatoes, rice, and pasta. That's your 4 big guns.
Yes.
Like heavy artillery sugars. And what do we do in America? We mix them.
Everything.
Burger fries.
Yes.
I'll take the pasta and bread.
Right.
And then you add on a sugary drink. And then you add on the bread before.
Yes.
And then you add on a dessert, and it's like, oh, wow. Jam-packed with sugar.
Right.
Worst thing you can do, though, is cut it all out. Now we're in that starvation state. So you just have to be thoughtful. And I think that's where people struggle the most. Most people who have diabetes in pregnancy, if not all, have not had to think about what they eat. They just eat.
They just eat.
And now you want me to think about, when I go to this restaurant, how can I put a meal together that's going to be okay? So I just want to eat any of it. No, that's not how it works either.
Right.
But you can be more thoughtful,
and strategic.
If you can get the burger with no bun, so you can have the fries. Or you can do a side salad or a non-starchy vegetable, so you have a full burger. Or how about this? Just eat like 2/3 of your meal now and save the rest for a snack when you get hungry. And it's those simple solutions that people kind of breathe a little bit and say, okay, I don't have to flip my life upside down to stay healthy. And it works well for them. And it's trial and error again. Some things you're like, oh, I didn't know I could have that. And you can. And some it's like, oh, thought I could have that fruit. It's a big
Right.
one.
Mm-hmm.
But it's fruit, but it's all natural sugars.
Mm-hmm.
So your grapes and watermelon, bananas, those things, if you eat too much, which yes, we've been told is a healthier snack than chips or cookies, but they still can get you in trouble.
Exactly,
Right?
because sugar.
Yeah. And the freebie I love is the switching out the drinks for flavored water. Right.
Sorry, guys.
Sorry. You can do like diet drinks. I don't fuss at anyone about zero sugar drinks, things like that. But some people have to, coffee. I hear a lot of Starbucks coffee. And I'm like, well, you can do a small, really small cup of regular coffee, not the small frappuccino with the whipped cream on top. Yeah. So I just tell patients all the time, hey, just start making your wish list and just put it at the bottom of your birth plan so everybody can go make runs, bring it with you to the hospital. So
Right.
Because we're literally going to back off. You can go eat whatever you want to eat
Right.
after that.
Right.
And if you're breastfeeding, you're going to actually, our whole story changes. Now I need you to eat extra sugar, please.
I can do all of that.
All the extra sugar.
Times 4.
Yeah.
No, I'm just kidding.
Like what you told me not to, but now you can catch up. You need it. It's coming out in that breast milk.
Because you need it.
So, yeah.
The baby needs
The
it.
baby.
And you need it. But no, it's cool.
Yeah.
Thank you so
You're
much.
so welcome.
This
We'll
was
say
so fun.
TBD.
TBD.
To be continued into more fun journey
Yeah.
things in
Yeah.
OB. See, this is what I say. The TV shows make us look like all we do is sit around and gossip and a baby falls out.
No.
OB is so interesting and intricate. It's so complex in all the right ways.
Yes.
And then this is the only time in life like you go home with a prize. From
I
the
know,
hospital.
right? It's the scandal of it all.
Surprise. Take it home. It's gonna love you and grow up and look like you and be all successful and take care of you when you get older.
Mm-hmm.
Can't do that when you get your gallbladder out.
I know, right?
Just saying.
Just saying.
Just saying.
Or your tonsils.
Yeah, I'm just saying.
I mean, you just
And we're only
want
touching OB. We didn't even get into anything GYN.
nothing.
On
We
the
talked
other
about
side of the
no.
no.
Yeah, no GYN.
Yeah, we're gonna have to call in another expert for that because
Don't you do
I
that
want to
too?
learn too. I do.
You want to call in another one?
Yeah, but we got to go like deeper than I can hit basic level. I can get you basic cable version. You need premium channels.
you want the Hulu version?
No,
More
no, I
private?
don't want the Tubi version.
You don't want the Tubi
I need
version?
like HBO Max.
Okay.
I need Apple TV. Right.
You want the streaming?
I want the streaming.
Okay.
Premium streaming.
Okay, Prime.
Because somebody's going to ask about menopause, and I'll be like, so here's the Tubi version. But then you're going to want like the big theater version.
Yeah, you want the theater
Okay.
version. Okay,
We can do that.
we can do it.
Yeah, I did learn it all. I'm an OBGYN too.
You learned it.
But
I
wanna
learned
make
it,
sure
but that
you
didn't mean
guys
a
are getting
thing.
expert information.
Exactly. Well, thank you so much.
You're welcome.
Thank you so much.
Thank you for having me.
This
Thank
was
y'all for
fun.
having me.
This was fun.
Yay.
Well, we're going to see y'all
Until
later.
next
Talk to you
time.
later. Bye-bye. That was fun.
That was